Good evening, everybody. I have a couple of topics to teach today. So, I will be starting first with evaluation of eosinophilia. So, before going to the evaluation, let's look at some of the definitions. So, what is the term eosinophilia is defined as increase in circulating eosinophils more than 500. Eosinophils can be divided into three different criteria: mild, moderate, and severe. The criteria is from 500 and to 5,000, and it is divided accordingly from 5 to 1,500, 1,500 to 5,000, and greater than 5,000 is called severe. Eosinophilia is associated with mild variety of allergic, rheumatological, infectious, neoplastic, and other rare idiopathic disorders, which we'll have a look at it later in the slides. Clinical manifestations range from benign asymptomatic presentations to life-threatening complications, including endomyocardial fibrosis and thromboembolism. Then let us look at the structure of a eosinophil. This is a structure of the eosinophils. As you can see, a binucleate granules binucleate nucleus, and a lot of granules are present, and based on the different receptors and the different ligands that are present throughout the thing, there are different medications that can be used to act against this structure in the eosinophils. Some of these medicines are to decrease the interleukin effect. Some of these are to increase the eosinophilic count. So, eosinophils have been implicated in the pathogenesis of tissue fibrosis, thrombosis, vasculitis, and allergic inflammation. The proximity of eosinophils to cause such effects depends on number of factors, including number of eosinophils, their location, and degree of activation. The granule protein that can be released from intact eosinophils through a process called piecemeal degranulation, whereas selective secretion of individual granules component can occur without disruption of cell membrane. The cell-free granules liberated by exocytosis during extracellular DNA trap cell death. So there are two processes by which these granule proteins can be released. One is cell-free granules, one is piecemeal degranulation. So the spectrum of hypereosinophilic syndromes can range from MHES, that is myeloproliferative HES, all the way to idiopathic HES. I'll be dealing with them as I come along, and I'll be explaining the differentiation between them. So once I get a patient who's complaining in a general, he has gone for a routine blood test and in which the eosinophil counts up high. So the high can be anywhere between above 5 to all the way around 20, 30. So at presentation, there are the few differentials that will come to me. That could be allergic disorders like asthma, atopic dermatitis, any medication he's taking, any infection he's suffering from, fungal, protozoa, helminthic, and other neoplasm. Any immunological disorders, which is a spectrum of hyper IgE syndrome or Omen syndrome, autoimmune and idiopathic like sarcoidosis, inflammatory bowel disease, IgH4 disease, and any radiation exposure, any drug he's taking like IL-2 therapy, and rare eosinophilic disorders like Churg-Strauss syndrome, which is polyangiitis along with the disorder. So these are some of the differentials that will come into our mind, and we have to take history based on what you're thinking that day. So in my initial evaluation, all the patients whom the eosinophil count is high, I will send for an absolute eosinophil count that will be measured in Newberg's chamber. Then following which I will do a LFT, send for immunoglobulin levels that will include IgE, troponin, serum troponin, ECG, pulmonary function test, a normal chest X-ray. And if the patient is having persistently high, that more than 5,000 is there, then I will do a bone marrow upfront and send for various tests like uh, there's a mutation panel which I'll be explaining later, which are the mutations which have clonal mutations which are specific for eosinophils, which we'll be sending for various tests. So, clinically stable hypereosinophilic patient, diagnosed, evaluation, and classification by clinical variant. Whatever would be the secondary cause, we treat the secondary cause. If they respond, we treat and reassess. If there's no response, we evaluate for myeloproliferative HES. If the PDGFR mutation is positive, then we treat with imatinib 100 to 400 mg daily. If there is no PDGFR mutation, then we treat like chronic eosinophilic leukemia NOS type, which again I'll be discussing later. And if the response is there, then it is a varied response. If there's no response, then we give systemic steroid. In case of myeloproliferative HES, if it is no single organ involvement, if the organ is involved, then consider topical steroids. If no, then consider systemic steroids. Now, if there is a potential life-threatening event, then we do a limited diagnostic evaluation and treat with higher doses along with ivermectin if potentially strong exposure to strongyloids, especially in patients who have come traveled from Africa and somewhere. If there's a treatable secondary cause or myeloproliferative yes, we reassess and continue monitoring the eosinophilic count for the patient. In the treatment guidelines, the treatment which we most commonly use for asymptomatic patient is mild form of corticosteroids that can vary from 1 mg per kg to 1 gram of methylpred depending on the severity. Second line would be to give ivermectin 200 microgram per kg per day for 2 days. It should be given in any patient whom you suspect to have any exposure to helminth. If there's steroid refractory, then you should start imatinib 400 mg. If it is lymphocytic hypereosinophilic syndrome, then you should treat with interferon alpha. If not, then hydroxyurea and interferon alpha. So now coming to some subsets of blood cancer which can present with eosinophilias. In AML, these are the four in AML subtypes. They are the three which can commonly show in version 16, translocation 1616, core binding factor and MYH11. Second would be translocation 821, RUNX1 and RUNXT1, and APML rarely can present. With this, some TLLs compared to BLLs can have eosinophilias at presentation. Now, these are the specific mutations which we send through NGS in which you are looking for clonal eosinophilia. So the mutations are FLIPI IL1, PDGFR fusion, PD, PDGFB rearrangement, JAK2 and V61F mutation, ETVS and PDGFRB mutation, translocation 521, and KIT 816V mutation. So this is sent in NGS, and if we get these fusion mutations like PDGFR fusion and PDGFRB mutation, then we can start with treatment of imatinib. Now coming to chronic eosinophilic leukemia, and how do we differentiate it from idiopathic hypereosinophilic syndrome? In chronic eosinophilic leukemia, the eosinophil count is usually above 1,500. There's exclusion of reactive and paraneoplastic eosinophils. There's exclusion of other hematological neoplasm that which can accompany eosinophilia like AML, which are the subsets I told you. Exclusion of T cell population with abnormal cytokine production. Evidence of eosinophil clonality, which I discussed with you, like FLIPI and PDGFR alpha, PDGFR beta, all the other mutations which we discussed earlier, increase in blast in blood and bone marrow 5 to 19, fusion gene that encodes for PDGFR alpha, beta, and FGR1, PCM, JAK2 fusion S. So these are the chronic treatment for chronic eosinophilic leukemia. This is how you read through the diagnosis. In idiopathic, the same level of eosinophil will be present, 1,500. To rule out any reactive hypoeosinophilia with extensive investigation, no evidence of eosinophil clonality, which will confirm by doing a bone marrow and sending for NGS, and persistent eosinophilia for more than 6 months, and a evidence of end organ damage. This is again the same WHO which gave in 2017 this entity of chronic eosinophilia leukemia NOS type. So in that they also said that there are few cases in which TED2 and EZH2 mutations are also present. AXL1 and DNM3 mutation found in elderly people without malapplied neoplasm, essential to exclude reactive causes of eosinophilia. So there were the other mutations that were added to it to other than the one which we already had. So this was one of the patients we had, a 42-year-old previously healthy woman with a 2-month history of worsening fatigue, weight gain, dyspnea, exertion, non-productive cough, orthopnea. She was afebrile but tachypneic and tachycardic. She also complained on physical examination. There was a right lower tracheal pedal edema bilaterally. A right lower lobe infiltrate was present in chest X-ray. Echo showed ejection fraction of 40% and left apical hypertrophy without thrombus. And these were the CBC parameters. So you can see that here eosinophils were 6,500 and the rest of the parameters were relatively normal, except for that ESR was elevated, and then we sent for serum IgE levels and they came mildly elevated. So the investigation which we did is again complete blood count with absolute eosinophilic count, stool for ova cyst parasite, IgE levels, bone marrow aspiration biopsy, and cytogenetics. So this is how usually I go about it. If I see a eosinophilic patient, I will take a detailed history, rule out any asthma, atopic dermatitis, any family history, send for absolute eosinophilic count, send stool for ova parasite, give albendazole 1 dose, then send for immunoglobulin levels, and then try to convince them for a bone marrow and send for clonality. So when the bone marrow was done, it was hypercellular with 29% eosinophils, 31% had reticulin fibrosis. Karyotype was normal. Patient was started on methylpred 1 gram intravenously administered and switched to oral prednisolone and fish. We were awaiting the fish reports to come. And fish came positive for FIPI1 and PDGFR mutation and was negative for the other mutations. So as the report came, we tapered off the steroid. Repeated echo cardiac MRI showed LV thrombosis. Repeat bone marrow biopsy was same. So we started on imatinib and now the patient is doing well. So this would be the first topic. If any questions regarding the first topic, please go ahead.
So, Dr. Amandeep had a question. When we are talking about eosinophilia, we take into consideration eosinophil count or absolute eosinophil count.
Ma'am, so there's a twofold answer to this. The first presentation which Dr. Mandeep will be getting is the what they will come as a from the printed machine, and in that the eosinophil percentage will be high. And then to verify it, he can always send for absolute eosinophil count. So that absolute eosinophil count is based on that only the criteria is given, ma'am.
So, it absolute eosinophil count is more reliable when we are thinking of eosinophilia.
Yes, yes, ma'am.
Right, because we have a tendency to calculate the percentage from the total count and
I
get an
understand.
approximate AEC value, especially when we think of cost effectiveness. So, in this, perhaps we may miss a couple of cases of.
Yeah, sure.
Yeah. Anybody has any question, you can unmute
I
and
have a
ask.
doubt.
Yeah, please.
Sir, I just wanted to know if in the CBC the eosinophil is normal and in peripheral smear it says mild eosinophilia, how do we approach that case, considering that the patient doesn't have any history of asthma or any other comorbidities or family history?
Yeah. So in that case, just do repeat a CBC after 15 days. Uh, so you'll get a better clarity. Sometimes mild eosinophilia with a normal count is sometimes over-reported by a pathologist friends. They will see 2, 3 eosinophils in one field, so they'll feel that okay, it would be more in other fields, so they will report it accordingly. But just repeat one after 15 days, and you'll get a better clarity. And tell them to focus on the absolute count of eosinophil if they feel that it is high, even in mild form.
Sir, I have a question. Normal eosinophil count with high IgE. So
Yeah,
what should we do in that case?
yeah.
Eosinophil count is high, absolute eosinophil count is marginally high, but IgE is very high.
Yes, sir. So
So
we
shall we go for allergic test or what do we do in those cases?
yes, so first you go for these allergic tests, sir. Do a chest X-ray, 2D echo, uh, rule out a history of any asthma and or atopic dermatitis, and also keep a watch for hyper job syndrome, that is hyper IgE syndrome, in which the counts of IgE will be very much elevated and the eosinophils will be only mild elevated. So in such patients, the treatment is a trial of steroids, sir. The patient will tend to do well, but we'll have to evaluate that further if the IgE levels comes very high. And on my experience, most of the patients who come from hill stations to Bangalore will initially present in a routine with some amount of eosinophils. And then they will have a workup that, when we came here, before that eosinophils were normal, and within 1 month or something, it will settle. So I don't know the exact reason, but I've seen a lot of in my OPD. Such.
Because see, what I have noticed is especially people coming from Bangalore because the Congress grass thing more in Bangalore. When
Mm.
they come to Delhi because of the pollution, there is a adaptability issues. Although the eosinophil count is normal, but IgE is more. So shall we take it because of the Congress grass? There is an allergic reaction, or shall we consider that this is because of the pollution and not adjusting to the airway quality here? They are having this problem, so it's becoming difficult, and there is no history of any drug allergy or food allergy or asthma or anything. But this is a pattern which I am seeing here sitting in Noida, especially for the persons who are coming from south, Bangalore mostly because of the pollution, the Congress grass pollution is there,
Mm.
and here the air pollution which is here. So
Yes.
how do you not tackle these kind of
Yes,
cases?
sir. So after I've done my thorough evaluation and I've not found anything, then I usually wait and watch, sir. And I explain them that it is seasonal, it will pass. That is what I do. And if it's not still going, then I give a trial of steroids in
So
such.
shall I start with prednisolone at least
No,
or
I
not?
would give no, sir. I will give it a month's time before to see how much is it. Is it mild? Is the Ig levels coming down in nature or not? If it's not coming down, then I would consider, sir, a trial of steroids.
Oh, okay,
Mm.
fine. Thank you, sir.
Also, you can do a skin allergen test and find out what is skin patch test and find out the allergen in a good center. And you can pick up the allergen and accordingly, educate and counsel the patient. So
Okay,
we
ma'am.
have couple of other questions. What is the role of cyclosporin and other immunomodulators in HES after steroids? Nishit sir?
Ma'am, as such, uh, the role of cyclosporin and other immunomodulators is very limited in because if the steroid is not working, so we have to look for a clonal because imatinib has a better response if the clonal mutation is present.
Okay. And how do we approach if we are dealing leukopenia in relation to eosinophils?
Ma'am, then I would do a bone marrow straight away.
Alva. Okay, fine.
Because if the patient is having leukopenia and
Mm.
the majority of them is eosinophils, then definitely I would like to do a bone marrow and send for the clonal eosinophil involvement assessment.
Okay, Dr. Shilpa has another question about your opinion on pre-surgical evaluation if eosinophilia is present. I think this is pretty common in Indian scenario. We
Yeah, so
definitely have to think of deworming once.
Yes, yes. So, see, that's what the stepwise approach which I've always followed is if the
Yes.
patient has financial problem, if the patient walks to me, gives me that I have eosinophil, I take a detailed history from family, allergy, any other known event in the past. Have you traveled from somewhere? Then I will tell him that if it's mild in nature, please take stool for send for parasite, and I'll give him one tablet of albendazole. Most of my patients, when they come next time, that problem is already settled. Now, in some cases, if it is not settled, then I will ask them that we'll do a immunoglobulin levels. After I've already checked the chest X-ray, 2D echo, immunoglobulin levels. If that has come back to be normal, then I will just let the patient be and keep monitoring eosinophils until it reaches a severe criteria. Otherwise, I won't give much importance to that if it's still in mild. That's
Okay. I think we can also take up questions after the part two approach to splenomegaly. Is it okay, Nishit sir? You start with the second topic?
yeah, sure.
Okay, sir.
Now, second topic for today is approach to splenomegaly. So, splenomegaly is defined as enlargement of the spleen by size or weight. So, a normal weight of an adult spleen is 70 to 200 gram. The spleen weight is 400 to 500 in splenomegaly, and spleen weight is more than 1000 gram in massive splenomegaly. So the what is the function of the spleen? The major function of the spleen is clearance of abnormal erythrocytes and removal of microorganism antigen as well as synthesis of IgG. Now there are a lot of causes for splenomegaly. Few of them I've just mentioned, like a liver disease, cirrhosis, hepatitis, hematological malignancies like lymphoma, leukemia, myeloproliferative disorders, any infiltration of a neoplastic cell like solid tumors can infiltrate and cause splenomegaly. Uh, Portal vein thrombosis, which or hepatic vein thrombosis, which you see in myeloproliferative disorder with polycythemia like Budd-Chiari can increase the vascular pressure, lead to splenomegaly. Splenic congestion in congestive heart failure, again in portal hypertension, and cytopenias such as Felty syndrome, which is nothing but rheumatoid arthritis and this splenomegaly as a triad of autoimmune rheumatoid arthritis and splenomegaly. Then, in such cases, also splenomegaly can be present. Sickle cell, hemolytic thalassemia, chronic infections, malaria, tuberculosis, infectious mononucleosis, and connective tissue disorders like SLA, rheumatoid arthritis, and adult onset still disease. All these are associated with splenomegaly. In children, so we have to look towards glycogen storage disorders, sickle cell, and in focal lesions where hemangioma, abscess, cyst, and metastasis. These can cause splenomegaly. Now, pathophysiology is that is congestive by pool blood leading to portal hypertension, infiltrated by invasion of cells foreign to the splenic environment, like metastasis, myeloid neoplasm, lipid storage disorder, immune by increase in immunological activity, subsequent hyperplasia, endocarditis, sarcoidosis, rheumatoid arthritis, and neoplastic when a resident immune cell will originate from there, like splenic marginal zone lymphoma. Now, symptoms wise, the patient will tell you there's a vague abdominal discomfort, usually on the left side, pain in the left upper quadrant, abdominal bloating with distant abdomen, anorexia. Constitutional symptoms like weakness, weight loss, night sweats suggest malignant illness. Then, in view of acute infections, when you're thinking about tuberculosis and underlying cirrhosis, hepatitis, any anemia which can cause where the patient will present to you dyspnea, lightheadedness, easy bruisability on bleeding petechia. In all those cases, splenomegaly can be there. So this is the Hackett's grading of splenomegaly. Before coming to that, I would like to tell you that usually there are three conditions. If you are suspecting them, and if splenomegaly is there, then you should rule that out. one is ITP, one is essential thrombocytosis, and one is aplastic. So in those conditions, if you are getting, and in sickle cell, later there'll be a autosplenectomy, but that will happen around the age of 12 to 14 years. So in such cases, if you are getting splenomegaly and you're thinking towards those diagnoses, it is advisable to think towards some other diagnosis. According to the Hackett's grading system, grade 0 to grade 5, no palpable spleen. In grade 1, just palpable, barely palpable on deep inspiration, not easily felt on normal breathing. Grade 2 is palpable 1 to 2 centimeter below the costal margin, but does not extend beyond that. Grade 3 is moderately enlarged, 2 to 4 centimeter below the costal margin, but does not reach the umbilicus. 4 and 5, one reaches the umbilicus in grade 4, and in 5 there's massive splenomegaly that goes beyond the umbilicus. Now, if the patients who have undergone splenectomy are at increased risk of infection secondary to encapsulated organism like Haemophilus, Streptococcus, and Neisseria, so such patients will require these vaccines and should be planned before splenectomy. uh, Vaccination against these organisms are highly recommended who have undergone splenectomy. So we know that if a patient is planned for splenectomy, we have to undergo these vaccination. But also important to point out that sometimes there'll be a splenic infarct for patients, and if the infarct is more than 10%, it is also recommended to recommend these vaccines. So this was the approach to splenomegaly and eosinophilia. Now again, I can take the questions.
Sir, one question. In presence of mild fatty liver, and if there is splenomegaly, then any cognizance of to be taken in that case? R- Routine ultrasound has mild fatty liver, grade 1, with splenomegaly. But
So
no,
yeah, I understand. So in that case, I also look at the portal vein with IVC width. If they are normal and the patient is not having any anemia and no thrombocytosis, no leukocytosis, no palpable lymph nodes, then I will just observe the patient. This.
Dr. Nishit, you said from hematological perspective, you have to look into three conditions where splenomegaly is important. So one is ITP, second is essential thrombocytosis. So can you help us differentiate with some clinical scenarios briefly? Because
I meant
ITP, yeah,
what I meant to say is that in these conditions there will be no splenomegaly. So
okay. Hmm.
if on
Correct.
examination you are finding splenomegaly and
Hmm.
on bone marrow report comes that it is ITP, it is
Correct. Hmm.
megakaryocytic hyperplasia, then I
Hmm.
have to evaluate further because ITP will not present with a
With
splenomegaly.
this, that's what we got confused. A little bit more about essential thrombocytosis.
Actually, ma'am, it is essential thrombocytopenia. It is comes in the criteria of classical myeloproliferative neoplasm, in which what will
Okay.
happen, the patient is having persistently high platelets, and once you work up the patient for iron deficiency, the iron profile will be normal, and the patient will generally give a history of that my platelets have been above 4.5 lakhs for 7 to 10 years. Then you send for a MPN
Mm.
reflex panel that can come positive for either JAK2, CALRA, MPL, or
Oh.
the mutation. So if it comes clonal mutation involved, then we have to.
हाँ वो तो बोल ही देता हूँ.
Okay. So, ma'am, so once
Yeah.
clonal mutation comes involved, then I have to divide the patient into low risk and high risk. In high risk criteria, the platelet count should be above 15 lakhs. Anything below 15 lakhs is coming in low risk. Less than 10 lakhs, the chances of thrombosis happening is very, very minimal. Above 10 lakhs to
Mm.
15 lakhs, there is some chance, but above 15 lakh, the patient will come into high risk. So this is what we divide, ma'am. The treatment
Okay.
varies from hydroxyurea with low dose aspirin, observation, or adding a JAK2 inhibitor, ruxolitinib, which is hardly ever required for such patients.
Okay. Because in clinical practice, we sometimes get worried. Sometimes the platelet is persistently 5 lakh, 8 lakh, even after a couple of repetitions. How long should we wait? Is there a lag period after which we have
Ma'am,
to get
if
alerted and referred to
so
a
if
hematologist?
yeah, ma'am. So if you get a patient with 5 lakhs, 8 lakh, take a history of any hemorrhage, uh, any bleed, that could be PV bleed, period bleed, any surgery that has happened, and look for
Or
in
recent sepsis,
yeah,
anything like that?
yeah.
Yeah.
Ma'am, usually thrombocytosis is not a sign for sepsis. If thrombocytosis is occurring in sepsis, is actually a good predictor because
Okay.
platelets are also predictors. So, but rule out iron deficiency. If iron deficiency is not there for the patient, ma'am, then we have to evaluate.
Okay. So we have couple of questions, Dr. Nishit, already. Is there any physiological condition for mild splenomegaly?
Uh, Ma'am, not that I am aware of. For mild splenomegaly, there's a physiological condition, but the technique to palpate varies from person to person. Uh, you cannot palpate a just palpable spleen. Most of them, ultrasound will only pick it up, ma'am. So if you have
Correct. Sonologists are
13.5,
better sensitive
yeah,
in picking up
pick it
splenomegaly.
splenomegaly because than us, because somewhere around 13 centimeter, which is hardly palpable for us, they would give it as a mild splenomegaly.
Okay. So what should be the duration to repeat eosinophil count in a case of mild eosinophilia under evaluation?
Ma'am, I would wait for 15 days after I have given one albendazole to the patient.
Okay, fine. Any more questions? They can unmute and ask.
Sir, in eosinophilia, do we need to directly start ivermectin or albendazole 400 milligram is enough?
Sir, albendazole is enough. Until the patient has a very strong history and it's an international patient from Africa where the exposure to such strongyloids is very common. So we
Okay.
at bone marrow transplant settings, if I have a patient with persistent loose stools and not settling, we do C. diff, we send for stool culture, but we also give ivermectin if it's not settling, especially in autologous, because we will think that it could be due to
But nowadays we have the drug called albendazole with ivermectin, isn't it? Sir? That the
yeah, yeah,
pan.
yeah,
So
right,
Yeah, yeah,
is
we
it a,
have many brands like
right,
Ivorol Port.
right, right.
so is it okay for that eosinophilic patient or first we have to
No,
start only albendazole or
no,
give
nothing like that. It is okay. You can give a combination for both. Yeah.
okay, thanks.
I think after today's class, people who have attended will never forget eosinophils for sure, and they keep looking at spleen. So if we get any abnormal readings or in your reports, patient reports, I think we can put it across, and Dr. Nishit is there to help us out. So he has just made us aware about eosinophilia and its significance, and also splenomegaly. Dr. Pradeep Gund has a question about the case. He wants you to describe the case in brief. The case you described had no thrombus before, and next scan it showed thrombus.
Let me look at the
I
case.
think, yeah. Cardiac MRI showed LV thrombus.
Yeah,
That's
so
what you have written.
sensitivity of cardiac MRI is very high.
Yeah. Agree, sir.
So based on
Yeah.
it, you go low fraction and do a cardiac MRI for that. Cardiac MRI sensitivity is very, very high to pick up a thrombus.
Any more questions?
Thank you, everybody, for
Mm.
patiently waiting. I was caught up in something.
Mm.
Sorry.
Thank you for that crisp presentation. I'm sure we'll have a lot of doubts and we'll get back to you. Please do share us the PPT and the link to the
Sure.
uh, assessment, and also this class recording will be shared shortly. I think we have to save the recording before we exit, sir, so that
Yeah, I'm leaving it as it is, ma'am. They're helping. Okay.
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 Okay, sir. Thank you so much.